Call for help. Help is on the way. Now what?
ACLS review, 11/11/21.
Yeah, I'm just going to go. What's going on with him? Go, go, go. Oh my goodness, he's not breathing. He doesn't have a pulse now. But you know what? A couple of things. You may have noticed we're all wearing masks. It is the times of COVID. Even if you know that he does not have COVID, we are treating every single patient who codes in this hospital as though they were COVID suspects, right? So what does that mean for us? PPE. We need PPE. We need all the PPE. Where's that PPE? Where's your PPE card? That's on the bottom drawer of the crash card, but you know what? Where's that crash card? It's not right here next to you. I mean, that one is right here next to you, but it wouldn't be right here next to you. It would be down there. It would be down there. Someone has to go get it. Meanwhile, here you are. Meanwhile, here you are. And are you going to do absolutely nothing while you're waiting for?
No, you start compression.
Right? How far away am I from you? Not even a foot. I'm sure. So here you are, right on top of it, and all that COVID breath is going right in your face. What can you do? He has a sheet. He has a gown. Just cover his mouth while you're waiting for PPE to show up. But make sure you cover up. Another big thing that I've noticed, especially here and having been part of the code team, is charting. That's what everyone hates to do more than anything, right? Because you're sitting there on the computer and you can't hear anything. And now everyone has their PPE on and everyone has their masks on. Go on, everything. What can you do? In these packets that I gave you guys, if you go to the ACLS cardiac arrest algorithm, some of you have already done it. So this is something that we're looking at doing that we kind of talked about for sure, but making copies of this, keeping them on top of the crash cards in a folder, just a piece of paper in a folder. When there is a code, you take this out and you start writing. What time did you start compression? Oh, started CPR. Did we give oxygen? No? Oh, no, maybe someone should ventilate. Give oxygen while waiting for anesthesia. Put them on the monitor. Check. Is it shockable? Maybe you're not super comfortable with rhythms yet. Maybe it's flashing at you, yelling, push analyze, push analyze. So you push analyze. That's okay. It's going to tell you if it's shockable or not. So right there, you know, yes or no. Yes, it is. Okay, great. What time did you shock? Do they have access? 18 in the left AC. Wonderful. 2 minutes have gone by. We've gotten some drugs on board. Where's your epi? Well, it depends what color crash cart you grab. If it's a lavender card, just grab that drawer right off the top. I like to just throw it on the patient's legs because I promise you he's not going to mind. And then you have all your drugs right there. If it's a drug box, find the surface to put it on. And everything is in there. And then just go down the list and write down all your times and everything. That way nothing gets missed. And you have the times for everything without having to go in real time and try to listen to things while trying to find the bazillion ways that we can give epi from the drop down. And then something gets missed. Someone asks you a question, you lose track of things. This way you can keep track of time and you can keep track of what's going on when it should be going on. Good? It would be blank. And you can write down, it's not today, but it would be if we copies. And you can write down everyone's name and pager number because you know when you're doing your charting that it wants that. Good? Questions? Sorry, we're flying through this. I just have you guys for very short time. So, with our condensed module today, we're going to actually run through a quick code. Good? And one of the biggest things and one of the biggest reasons that we are doing this is to work on our team, communication, figuring out roles, team leader, what your roles are within the code. So how many people do you normally have for a code? Does everyone come running? Well, there we go. Everyone comes running. Who does what?
Anesthesia calls the shots and nurses.
And they're like, hey, you, because do they know all your names when you're wearing full PPE and you can't see your badge and you can't even see your eyes? No, so hey, you can, someone give up, well, who grabs it?
Either nurse.
Someone does, and then it's like, well, me, are you talking? Oh, you already got it. Great. So communication is gonna be huge. Another thing that I recommend, and I actually brought them with me, are the little name badges. Other units have them pre-printed with the rolls. You can put your names on them, stick them on your gown, stick them on your cap, on your shield, whatever. But that way, you know, this person is giving drugs. This person is going to be in charge of access. This person is going to be ventilating. This person is going to be doing whatever. So something to think about going forward, because we're about to bring in the resident and the attending to our little code here to really see how we work with our communication. You guys ready? Questions on anything? And again, I apologize for doing this a little bit scrunched. All right, let's do it. So who wants to start off with being a part of the actual mock code? Let's take like 5. Come on, don't be shy.
Emily.
Get in here, guys. Listen, there's so much candy.
Basically, you want all of you guys to watch and listen, and if you have ideas, but there's only ideally 5 people running the boat. And our attending and resident, they know that we are gonna go get them. We're gonna come, like, so whoever ends up going to get help.
Oh, here, man, jump in here. John, they want a doctor. All right. So you guys are hanging out and you find that our friend here is unresponsive. So. Sir, help, we need help. Do I go actually get them?
I got the credit card.
I'll get them for you.
Okay. No, really, go get them. Go get them.
Hey guys, I'm Jordan, I'm the anesthesia attending. What's going on?
He's unresponsive.
Is he pulseless?
Yes.
All right, you can start compression,
Can someone
please.
get the backboard? Yes.
All right. Can someone tell me a little bit about what story you're getting pads on? Once we get that second pad on, thank you. Can someone please call Can you please I'm the team leader. Can you please get 1 milligram of epinephrine ready, please? Tell me when it's ready. Did you call Joy, can you call you're my medication person. Can you call an anesthesia staff stat?
I did.
You did, thank you. So we're getting additional help here.
Lorelai, can you get ready for next compression?
Can you let me?
What? I'm already tired. It's like, I just prepared Hurry.
If you guys aren't doing anything actively, you guys try to not talk. I'm sorry, my lightness. I'm assuming the pads are on.
Yeah, okay.
Okay, so it looks like beat bib to me.
Okay.
So I think we should defibrillate with 360 joules. Okay, keep doing compressions until we're ready and charged here.
Ready.
Do you have
Charging. Clear.
Okay, clear, everyone's clear, go ahead. Okay, back on compressions, please. And you two are okay alternating compressions, okay? Is the epinephrine ready? Do we have good IV access? 18 gauge in the AC. So 1 milligram of epi is going in. Let me know every 3 minutes if the epi, okay? So while we're doing compressions for the next 3 minutes, can you guys tell me a little bit about what has gone on?
So, Emily, were you?
Hey, Tyler, can you be in charge of airways? Absolutely.
I was gonna say.
What would we, sorry.
I don't know, I just want.
You don't know the history,
Yeah, the
okay.
55-year-old that had a.
And that is the honest to God truth. That is more real than real.
Okay. Any ideas of why he became hypoxic?
Why?
We got a history of COPD.
Yeah, okay, sure thing, we'll get there. So Tyler, the plan, I would plan to intubate, but once we get all the, I'm gonna guess some anesthesia people are arriving with their. Can you guys, can someone please get the airway part, since anesthesia is not here yet? You guys, if you don't know where it is, thanks.
We have airway right here.
If you want. I'll take a, we have suction available. I'll take a neck board. Suction, 701. Here's suction. Great. We got suction.
2 minutes.
Yeah. Ready, full stop?
Yeah. Sure.
You know.
She was gonna get the credit card, so she left.
Sylvie, let's go ahead and charge again and get ready to defibrillate and do compressions until we're ready. Yes.
Clear.
Let's just go ahead and defibrillate. Okay, back on compression. Okay. You want to just give it to them and assume it's working? Thanks. Okay, great. There's 2. All right. Has it been, how long has it been since our first happy?
We could get up in 1 minute.
Okay. We have it ready to go.
Okay.
Would
you like me to start another IV?
Sure, that'd be great. You don't have another job to do yet. I have drug person, and compression people, airway person. That's been called. So now we're basically just doing ACLS, okay? And we have to think about, I think getting an airway in and oxygenating this person is going to be the next step. Tube is in, great. Can someone please call respiratory therapy? Yes, are you going to do it? Close the thank you. All right, so we're just gonna bag with the ambu bag until RT can get here again, okay?
Here's our end-tidal.
Okay.
Where's the tube secured at? We got it.
All right, go ahead.
How much epi?
1 milligram of epi in the 18 gauge
At night.
IV. Okay, and just keep letting me know what that interval. Okay. Can you get some amiodarone available as well? 100. Let's do 300 milligrams of amio. Oh yeah, keep going. Just
RT is here.
RT is here. Thank you, RT. This patient is coding and has just been intubated. You think we can put him on a vent?
Anyway, check our pulse.
We have a
Check our pulse.
This is the whole.
Okay. Very weak. Do we have a blood pressure?
What's our blood pressure? Our blood pressure is 70/40.
Okay, so we have a pulse. So I think we should, we're fine to stop compressions, but we need to bring the blood pressure up. Can you give some phenylephrine?
Would you like the wide open fluids too?
Yes, wide open fluids, please.
How much phenylephrine?
Do we have a second IV yet?
Yeah, we did, yeah.
Yeah, I would just have fluids going wide open on both IVs.
Okay.
I got a 14 gauge.
Wow.
It looks like we have sinus rhythm 73, but we're hypertensive, so I think at this point we can just give some vasopressor to try and bring the pressure up. And so we've got Ross.
Lab, EKG.
Yeah, that was the next thing I was getting at. So now that we've got Ross, I think we have an opportunity to get to have the clerk call for an EKG and a chest X-ray.
I'll draw labs.
And preferably if someone can get a venous blood gas, but for now, but it would also be nice. RT, would you be able to do an arterial blood gas?
Yeah, I can try.
You can try. I'm assuming there's no other anesthesia folks around right now too. To do anything. Yeah. That's usually my go-to after RT.
Someone give me stickers.
What's the blood pressure now? It's still, if he's still relative, slightly.
His blood pressure now is 85/60.
So we don't need to do compressions. So I think that we're fine to just, he gave the phenylephrine.
Yeah.
Yeah, he's
Should
not
we sedate
responsive.
him? Not responsive.
I don't want to stay right now.
Okay.
What? Does anyone have any suggestions of what you want to do at this point?
Transfer to ICU.
Well, we were only arresting for a few minutes, so I'm hoping that we don't need to cool him. At this point, I'm just gonna, we're just going to, I would have the fluids wide open and start phenylephrine infusion.
And if he were to wake up, we would give him throat.
Right, but at this point, I don't think we need to sedate him because he's not responsive, but need to figure out a disposition for this person. He's obviously going to be going to an ICU.
Oh, we should also call the surgical team.
Yes, lap chole. Does general surgery know their patient coded in PACU? Can someone make sure they know? Yeah.
Probably.
Got it.
Also, I checked the EKG, there's a signs of STEMI and if patients have command.
So we said labs. I'd like to specifically send CBC, basic, venous blood gas, troponins, all that stuff. And then your arterial blood gas, if we can get one. I assume we'll have an anesthesia tech here. They can go run the gases for us. And anything else, Tyler?
Arterial line.
Yeah, I would probably, well, we have good access at this point, but we probably will need that eventually if we need to give epinephrine infusion. Yeah.
We contacted the surgery, we have a bed in the CQ.
Yeah.
Yeah,
So, and we have a disposition now, and we're going.
I'll call CPR.
Report.
All right, guys.
I guess, what's the next? Is there anything else we need to be
He
doing?
goes to the CPR.
I mean, I'm not super happy where his blood pressure is, but I think we can nudge that up. It's not like an
Oh, he's on the
emergency.
fennel infusion, it's now 100/72.
Sure. The last thing I would do is just kind of like a differential of what happened, differential diagnosis of what happened. So I would say it sounds like respiratory arrest. So obviously that's not a problem anymore because we're intubated, but for some reason it sounds like he was hypoxic and then arrested from that. I would have expected him to be in PEA maybe and not BFib from hypoxic arrest, but that's not necessarily true. It's possible that he's bleeding from lap chole from something near the liver, so that we'll have to see what the CBC shows. We might want to, we'll just have the blood going, the fluid. So that's probably my differential, not knowing anything else about the patient's history other than that. But at this point, it's just keeping him stable until we can go to an ICU. I think, yeah,
That's the patient.
Anything else, you guys?
So is the patient following commands? Is
not yet. But like I said, I don't think we need to worry. At least that's what Emily told me. So Emily's just,
What do you think, Greg?
I'd be a little concerned that we have a normal blood pressure and he's not mentating, but let's just say that he's starting to move around and come to. Yeah.
It's okay.
Because otherwise, because we can't,
You're fine now. You're okay.
because we recognized this right away. We started compressions right away and we weren't doing it for very long. So I presume he's neurologically intact. We've done everything
He's squeezing my
correctly. So,
hands, young man.
okay. All right.
Good job, guys.
Getting broke now.
Any other suggestions, any other feedback? Or thoughts? Sarah, I don't know
So
if you have
let's talk about how that went. How did you guys feel that went?
it was good. Everybody responded.
We're doing CPR with
In the
no.
moment, he doesn't have a pulse. We need to perfuse him. He just went down, he still has a little bit of oxygen. Ventilation is not a super priority right there. What I loved about this was communication was amazing. that team dynamic, fantastic. What we don't see often, and we did here, was you call people out by name, very specifically, because we talked about this right before we started, assigning roles immediately, so everyone knows what they're doing, so there's no confusion, there's no crossover, and everyone knew where they were. That closed loop communication and even asking for closed loop communication is really the way that we're looking at it. So from my standpoint, this is exactly how a coach should be. Did you guys all feel the same way? Yeah. Did this seem nice and smooth and fairly easy, considering that no code is ever perfect and it's always going to be a little chaotic?
So one of the things, can I?
Yeah.
So one of the things when we have a code in the package, like an actual code, where usually it's probably respiratory or bleeding most of the time, right? So we usually call a staff stat and we get 1,000 people, but it's people I need. Sometimes I need an RT, I need an anesthesia tech to run labs and get me things, and I need 3 or 4 folks from anesthesia. You're gonna get 15, but how you guys, there's a lot of people here. Sometimes this is how many people there actually are, but I think it's key to just kind of observe and don't really talk. It needs to be kind of quiet in this zone, right? And a lot of times there's just chaos because everyone's like, what's going on? What do we need? Call this, what's going on? Blah, 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 blah. And it's like, everyone just needs to, it's an emergency. Everyone just kind of shut up for a second, please. And focus on, everyone that has a role and be in their role and then be available to jump in. And because sometimes I don't know and name badges help, but I might be like, Dina, go please do this specific thing. And then you can confirm back to me. I work in the cardiac ORs a lot, where we have perfusion and surgery and anesthesia. So it's 3 different teams. And closed loop communication is like what we deal with all the time. So if someone doesn't say what you told them to do, then just assume they didn't hear you. So I think that's like, it adds to the chaos when I say, can someone please call for an EKG or can someone please this? And then 5 minutes later, I'm like, does anyone know where EKG is? And they're like, oh, no one actually called because we thought someone heard it. That happens a lot. So
some of the best codes, I think, those of us that work in ER too, like they're quiet. Like they're just quiet and controlled and very direct. And so I think that's where we do sometimes fail because there's always chatter, there's always like this panic, but we want to keep doing this so we do feel more comfortable. So you just know what needs to be done. So you feel like comfortable getting those directions from the team lead and just you confirm and you do it and work together.
And most of the time when you're in cardiac arrest and every situation is a little bit different. But I mean, once you start compressions and you've got your medication plan and you've got your plan to check, for a pulse every 3 minutes, there's time.
There's like time.
There's time to be quiet and say, what studies do we need? What other people do we need here? But there's no reason to like have this level of chaos. You know what I mean?
Yeah.
It's never like that, though, is it? But
this was good though. I think that like there was time, like a bit, and as we get more comfortable with it, and just remember that like you come up upon a patient, this is happening. Like try to keep yourself calm and just know to like be a good listener and that direct communication, and that will set us up for success every time. Cool. Anybody else? Any other feedback?
I was just gonna say one thing, and it's because I've had it happen where we've called or what we thought was a respiratory code and ended up being like a hemodynamic, cardiac failure because we had no blood in the pump. So the one thing that we have to remember here is our tubing is not set up for blood transfusion. So once we recognize that we're probably in a situation where it's an emergency, all the tubing that goes on the IV should be blood tubing if we can. Because we can use it for anything we want if we don't need blood. Yeah. But if we don't have the blood tubing, we don't have it.
There's blood tubing in the crash.
I would say the crash cart.
And on our walls and our shelves, we have it as well. But it's just something to remember in this environment.
Any other feedback? Sarah, I don't know if you had anything else, but.
I'm thoroughly impressed. I think that was fantastic. You all worked really well together, and in this situation, team lead really controlled the situation. Was able to do everything.
Is there anything else from like the nursing perspective, like just like the big issues that other than like kind of it just being chaotic? Is there anything
I
else?
feel that when a code is happening, I've actually never seen like a cardiac arrest code here, but like on bird, you know, like the nurses kind of get like kicked out and like we can't even like see the patient. Like anesthesia kind of comes in and I know that's like totally your guys' thing, but like it's hard for us to like even see what's going on to like document on our patient.
Yeah.
Because like I feel like it's a closed loop between you guys, like,
Yeah.
and then we're like an outsider over here trying
Okay.
to like also know what's going on, but
Yeah.
we're kind of just like on back.
Well, and the last thing that you're bringing up about that is that's where we couldn't give information about the patient,
Yeah.
right? Because if you're so far removed from the patient you're taking care of, they're not getting the history of what transpired before this event
Yeah,
occurred.
so many, like you said, so many people just like show up and jump in.
Yeah.
And then we kind of get like slowly but surely like stepped out.
Okay.
And so I think that would be
It's
something.
it's kind of on the team leader, I feel like,
Yeah.
to reiterate that if you're not
Like
directly given,
nurses are in here also.
yeah, if you're not directly performing a role.
To remember too, just that, like you guys are used to your anesthesia techs run and that, but we can do some of the running too, or like our techs are here and they want to help out. And so I think that we come and then it's like cause I know my anesthesia tech, I'm gonna like, you know,
Yeah.
but that's just something that I've noticed in the past of like, we are available as well, you know.
Just, you know,
Just
anybody
think-
can run on. Just, you know,
Sometimes it's
whoever
hard, yeah.
volunteer needs to run.
It's hard to know
And
who's
also
doing
because
what,
you
obviously.
guys are familiar with each other. So I mean,
Yeah.
probably like know.
It happens
Yeah, kind of how
where
you work together.
once we get a bunch of anesthesia folks in, they're the ones that I'm gonna say, put in an IV, put in an A line,
Right.
do the airway, you know, that kind of thing, you know, asking them but I think that the nurse who was providing care to the patient prior to the event is vital to, because you were the one that knows how it happened.
Right.
So Emily knows whether this was, you know, were they hypotensive before it happened and then they had respiratory issues? Like, is it related to bleeding or were they hemodynamically stable and then they just aspirated or obstructed and it was legit respiratory related? And so I don't know that until, none of that is super relevant until we get Ross.
Right.
But once we get Ross, then that helps decide like, how do we keep him from arresting again?
Yeah.
You know, and so that not knowing that info from the nurses.
Yeah. I feel like it's also the documentation aspect, like sometimes we can't even see what's going on to be able to then chart it in our patient's chart. you know?
Yeah, I mean, helped me because you were standing next to me with a piece of paper and a pen. That was one of my things I was looking for with a scribe.
Yeah.
That's more important than you think because time goes weird in these situations, right? And so to have someone be, seems like it's been 8 minutes since the last epi. No, it's been 2. It's been 2 minutes.
Yeah.
So,
Or be like 5 minutes.
Sarah, did you,
Yeah.
or I don't know where she's at. Oh, I'm like, did you point out, like, and maybe you were doing that, Mark, like, I think it was a great point that you made last week that if we have these copies and you just like right by the bench,
Such a
12,
good idea.
15,
That's a great idea.
yeah.
yeah.
Oh,
Oh, yeah.
I think that we've never done that because they're always laminated on the side
Yeah.
of the folder. So,
So if we have
so
that,
if we have just copies of it
Yeah.
like this,
Yeah, no,
then
that's
all you
great.
gotta do is write the time
and
and
then
the
we can,
job.
Yeah.
and then we're gonna chart in the code narrator.
Exactly.
Eventually.
You know, I have Amanda really, but she.
They update it every time I
Yes, the
take.
nurses get exploded, but I think the nurse that should be there.
And that's usually how it is.
Yeah.
That's the other problem.
I think it's just everybody trying to help, be helpful, that's all.
Yeah.
That's primary.
Out there and be a part of
We
it.
need to do
Yeah.
a better
Agreed.
job of that. Like, I think sometimes it's hard because it's like,
Yeah.
the first person who shows up, like in this case, would have been me.
Yeah.
Or what if it was the person who was taking care of him in the OR, and then they get here. Is it another person witnessing later? you
Yeah.
know?
Yeah,
So
yeah.
I can see if I did
Transplant team
see
P,
suggestions for
try to
doing something.
explain.
I feel like yeah.
Because the last time I was representation about
Oh, yeah.
And they weren't. And the ICU we had. I know, Belfry.
Yes.
Yeah.
And this might not be the part.
So when you drop drugs, unless you're.
These guys are doing. These people are on Zoom and recording. I'm gonna go set up the PowerPoint and see if Tyler wants to then continue. So no, it's good.
Yeah.
With all of your code back, you can slap it on the.
Yeah.
Where? I'm gonna go set up the PowerPoint or the projector. We'll see if we can get through some of your materials.
Yeah, no worries.
Overlapping, but
Well,
I'll try to gather staff over here.
yeah, what are you doing now? Check to see if anyone's come up.
Okay. Okay, I think Tyler's gonna do a little presentation, just a review then of algorithms.
Oh, wait. I think so. But I don't know how we get. But because the God That's pretty good. We're only a little though. I don't think it's that. I'm a very cold person. It was free. I felt good over there.
I gotta switch to my fuzzy Crocs. My winter Crocs.
I can't wear those.
Trick or treat. Are those the whole?
I want to smell you. Listen, I've been able to wear them. You don't want to run up here. Come on.
I think I got it up and rolling here.
And then I just grab this stuff. I don't know.
That's cool. I'm trying to find present.
Oh, it's up top, right above.
So
Oh, slideshow, and then this. Okay, so I think you can see it, and you should be able to see your notes if you do.
Okay, guys, we're just gonna keep going, so we can, give some time to review. Like I said, there's kind of two-part, with Sarah, and then Tyler's gonna just roll into a little bit of like airway stuff and ACLS algorithms. So you can give him your attention now. We'll go through it.
all right. So my name is Tyler. I'm a CA1 on my PACU rotation. So a patient that's coding or paired-coding, this is often done by you guys, and then after the code is resolved or ROSC is obtained. Primary assessment is, you can remember it with A, B, C, D, E. Airway is a patent. They need some type of advanced airway. Do they need suctioning? B is for breathing. Are they taking adequate tidal volumes? Are they maintaining their oxygenation? If they're on a ventilator, how is the end tidal CO2? What's their skin color look like? Do they need supplemental oxygen? C is for circulation. So if they're having CPR done, how's the quality of it? Are defibrillator pads attached? Do they have adequate access? What's their volume status like? Are they dry? Do they need any vasoactive medications or antiarrhythmic drugs? D is for disability. It's primarily talking about neurologic status. Are they responsive? Do they have pupillary reflex? And E is for exposure, kind of referring to temperature or kind of assessment of the skin. Do they have a rash? Could they be having an anaphylactic reaction or something along those lines? And secondary assessment, this can be done by peripheral people if code is going on, or after ROSC is obtained, see what signs and symptoms the patient's having, what allergies they may have, any pertinent medications and the dose when they were last given, any pertinent past medical history, had they had recent MI, stents placed, recent brain bleed, anything like that. Last meal, it's probably less relevant in the PACU. And then any events leading up to the code. Secondary assessment also includes looking for common causes of the code. You can remember this with the 5 H's and T's. So for the H's, you have hypovolemia, hypoxia, hydrogen ion or acidosis, hypo or hyperkalemia, and hypothermia. And the T's include tension pneumo, tamponade, toxins or drug overdoses, or pulmonary thrombosis or coronary thrombosis. And I have not seen a code since being here, but I'm assuming the most common are probably hypovolemia and hypoxia. But you guys would know better than me. So we already talked about the team roles, but just to go over them again, it's important to establish a team leader quickly. Most likely it'll be the anesthesia attending. There should be 1 or 2 team members, possibly RT managing the airway. If advanced airway, such as LMA or endotracheal tube is placed, they'll be doing that. Or if they're bag masking, you may need 2 people on the mask, or 2 hands on the mask and 1 person bagging. There should be a team member attaching the defibrillator pads, managing the defibrillations. Someone should manage the IV access, make sure there's adequate access, giving fluids, drawing labs, anything that's needed like that. And then there should be a recorder. We talked about how important that is throughout the code. Just cover chest compressions. As you all know, should limit the interruptions less than 10 seconds ideally. It's not always possible, but that's ideal. Compressions should be a depth of at least 2 inches. I think they recommend 2 to 2.4 inches, but over 2 inches is fine. The rate is 100 to 120 compressions per minute, allowing complete chest recoil. And compressors should switch every 2 minutes, but it may be sooner. It is very tiring, as you guys know. And pulse checks along with rhythm analysis every 2 minutes. A way to monitor if you're performing adequate CPR, end tidal, if they have end tidal, if they're on the vent. So you look at the waveform capnography. Ideally, end tidal should be over 10 millimeters mercury. And right here in the top row, you see adequate chest compressions. I think it says 20, end tidal of 20. And here in row 3, you see inadequate chest compressions. And then more commonly, we'll have an A line present. And if they do have an A line, you want diastolic blood pressures to be greater than 20. And this correlates to coronary perfusion pressure, which is the right atrial, diastolic blood pressure minus right atrial pressure. So the higher you can get the diastolic pressure, the more perfusion the heart will have. And then I apologize in advance. I was not aware there was a new ACLS edition out, but this is the cardiac arrest algorithm. So you find a patient's unresponsive, you immediately call staff stat, start chest compressions, attach the pads, and assign team roles. So breaking down the algorithm, left and right. So VFib and pulses VTAC are shockable rhythms. So you'll start the high quality chest compressions, give supplemental oxygen, attach pads. If on rhythm analysis, you see VFib or pulses VTAC, you'll immediately give defibrillation and continue CPR while it's charging. At the end of 2 minutes, then you'll resume chest compressions. At the end of 2 minutes, you'll check the pulse, check rhythm again. If still in a shockable rhythm, you'll shock them. At that time, you can start considering giving epi 1 milligram every 3 to 5 minutes. And you'll repeat that cycle with chest compressions, 2-minute pulse and rhythm checks, and shocking if they're still in VFib or pulses VTAC. And you can then at that time consider giving amiodarone. First bolus will be 300 milligrams, and then subsequent boluses will be 150 milligrams every 3 to 5 minutes. And this is just an image of VFib. There's really no normal QRS complexes, rate you can't really determine, and there's no rhythm whatsoever. So this is the other side of the algorithm, the non-shockable rhythms, I guess you could say. So pulseless electrical activity, it can be organized, it can even look sinus, or maybe semi-organized, but there is no pulse. And the two most common causes are hypovolemia and hypoxia. And asystole is essentially a flat line. There's a picture of it at the bottom. You'll start out similarly to VFib or pulses VTAC with compressions, supplemental oxygen, and attaching defibrillator pads. The CPR for 2 minutes and pulse checks and rhythm checks every 2 minutes. And it's important to keep those interruptions and chest compressions less than 10 seconds. And it's important to start epi early, same dose, 1 milligram every 3 to 5 minutes. Because you can't shock, you really rely heavily on the epi. And then throughout this entire algorithm, both sides, you consider the reversible causes, 5 H's and T's. And this is another depiction of it. I kind of like this more just because it shows how continuous the chest compressions are. And you only interrupt for defibrillation and pulse and rhythm checks. So this is tachycardia with a pulse. If it's a new tachyarrhythmia, you go through your ABCs, airway, breathing, circulation, you check vitals, provide airway support, supplemental oxygen, consider underlying causes, and even get an EKG if time allows. The main branch point here is whether the patient is stable or unstable. So if the patient's unstable, like hypotension, altered mental status, or chest pain, you'll go ahead and provide synchronized cardioversion. You can also give adenosine. I've not seen it done, but you can give it if it's a narrow complex tachycardia and they're unstable. However, if the patient has a wide QRS complex that is not regular, you would just give a defibrillating shock, and that would not be synchronized. So the patient is stable, you have a little more time. The next thing to do is determine if the QRS complex is wide or narrow. So if it is a narrow complex, first thing you can do is try a vagal maneuver. So you can try carotid artery massage, or you could do ask them to perform a Valsalva, see if they can break it themselves. You can give adenosine if it's narrow. You can also try a beta blocker or calcium channel blocker. On the other hand, if it is tachycardia with a wide QRS complex, you can also consider adenosine if it's regular. You can also try other antiarrhythmic infusions. Sotalol, procaine mod, and amio are possibilities there. Bradycardia, again, go through your ABCs once you identify it, see what could be causing it, check their vitals, supplemental oxygen, airway support, EKG if you have time. And again, determine whether the patient's stable or unstable. Unstable or a stable patient, you can just monitor and try to figure out what's causing it. A lot of times they may have just gotten phenylephrine from an OR, and that could be the cause of it. And a lot of times it can pick back up. As we know, opioids can also cause bradycardia as well. And if they seem to be unstable with bradycardia, so if they have hypotension with it, your first line drug is atropine. And this algorithm says you start with a dose of 0.5 milligrams, but the new guidelines say you start with 1 milligram. If that doesn't work, you can try dopamine, epinephrine, transcutaneous pacing. The most definitive treatment would be transvenous pacing. So you can do those things to temporize so you can get transvenous pacing. These are examples of bradyarrhythmias. First one, you have second degree AV block type 1. So you see progressive PR intervals until eventually the QRS is dropped. And B, second column, looks like a second degree AV block type 2. So you see constant PR intervals with eventual non-conduction of one of the intermittent non-conduction of a QRS complex. And C and D show third degree AV blocks. C appears to be third degree AV block. So the RR intervals are constant, as are the PP intervals. But C looks like it's a ventricular escape rhythm because the QRS is wide, and D looks to be a junctional escape rhythm because you have those narrow QRS complexes. And then just talking about airway management. To review, respiratory distress is just any abnormality in respirations or effort, and respiratory failure is pretty much the end stage of respiratory distress. You have poor oxygenation, hypercapnia. I'm not going to go through all these, but we know a lot of these common causes of PACU hypoxemia. I think a major one is atelectasis, so using that incentive spirometer can be a big help. EQ mismatch can occur, especially after being on the ventilator in the OR. Obesity, majority of our patients. There's many reasons people may become hypoxic. Hypoventilation, I just want to primarily mention residual anesthetics and neuromuscular blocking drugs. That's probably the most common, as well as COPD. And common cause of PACU airway obstruction, which you guys see a lot. OSA is a major one. Laryngospasm, I have not seen, but I'm sure you guys have seen before. Glottic edema, that's probably less common, but secretions are a big one as well. Treatment includes supplemental oxygen, head tilt, jaw thrust, putting in oral airway or nasal airway, and then you can consider CPAP, BiPAP, or more advanced airway, such as LMA or endotracheal tube. And this is just a depiction of some oropharyngeal obstruction in figure A. Then B is just a simple chin tilt, and then you have jaw thrust in figure C. And you guys are very familiar with different oxygen delivery devices. This chart is actually inaccurate, but I'll point it out in just a second. So the nasal cannula, you can use 1 to 6 liters of oxygen per minute, and 1 liter of oxygen can increase your FiO2 by about 4%. In this table, with 1 liter, this should read 25, not 20. I don't know where they got that number from, but just want to point that out. Simple face mask, you can deliver a little more oxygen, 6 to 12 liters. A Venturi mask, you can determine the FiO2 the patient sees. I have not used it often, but I think it most commonly would be helpful in COPD patients because they rely on that hypoxic respiratory drive. So you can titrate it to their respiratory rate, essentially. And non-rebreather, I don't think you get a total of 100% FiO2 because the seal can't be the greatest, but it is fairly high. And the high flow nasal cannula we don't really use in PACU. And trach mask is similar to a Venturi mask. And then mask ventilation. So if a patient is in respiratory failure distress, you can use mask ventilation either with an ambu bag, a Jackson Reese, or even the vent. Jackson Reese is best for patients spontaneously breathing. Since there's very little resistance, they'll meet when they inspire. However, an ambu bag, it's pretty tough for a patient to take a breath with. So if they're giving good effort, I would not use an ambu bag if they're desatting. And then this is the technique. It'd be easier if I could just show you, but essentially with your index finger and thumb, you make a C on top of the mask. And then these three fingers grab up on the jaw and pull forward. It's important to know that you're not pressing down on the mask. You're actually pulling the patient's chin and jaw towards yourself. And it's can be tiring, so it's best to keep your kind of elbow tucked and kind of lean back. And then you're just providing counter pressure with these two fingers against the face. And mask ventilation can be surprisingly difficult. And these are a couple factors that increase the difficulty. So age greater than 55, high BMI over 30, which is a lot of patients. Beard or lack of teeth just make it difficult to get a seal. Excess soft tissue in the oral pharynx, it can cause snoring, and higher melanopodic class make it difficult. Neck radiation can limit neck mobility. Just being male in general increases difficulty, and then limited jaw protrusion and any airway tumors or masses can make it challenging. So for a challenging mask, you can use oropharyngeal airway or nasopharyngeal airway. So the sizing, you basically line this guy up, so with the corner of the mouth, and you want it to reach the angle of the jaw or the bottom of the earlobe, either one. And you can insert it a couple different ways. You can insert it completely upside down. So put it in the mouth upside down, and as you insert further, you twist 180. Or you can use a tongue depressor. You don't always have those on hand though. So if you use a tongue depressor, you just push the tongue all the way down and just slide it in right side up. And typically in the ORs, we'll use these yellow ones for females and then the red ones for males. However, it is all patient dependent. And you should avoid it if they do have a significant gag reflex. You don't want them vomiting and then aspirating. Or usually patients are awake enough that you're not at risk for the laryngospasm out here, but I guess it is always a possibility. And then you have nasopharyngeal airways, similar sizing. You want this part, the end, to be at the tip of the nose, and then this end to reach angle of the mandible. You insert it after lubricating the end with a bevel towards the nasal septum. So this would ideally go in the right nostril because it's kind of shaped accordingly with a bevel towards the septum, and it follows the nasal kind of curvature fairly well. And ideally use as large as you can fit in the nasal cavity. I would be a little cautious to do it if they just had like sinus surgery, or if they have like history of like significant epistaxis, so they could have a bleed, things like that. And then if with these adjuvants, if you're still having trouble, then you just switch to the bag mask, the two-handed bag mask approach. It's similar to the single-handed. However, I usually do, I usually do this bottom one right there, the VE technique. It's just a little easier for me. You can really crank up on the jaw with that method versus the CE method. It's just a little more difficult. I think that's about it. Any questions, comments? Anything, Dr. Fenwa? Thanks. There's donuts behind where the residence, PACU residence sits. Yeah, help yourself. Sorry, I should have brought them over. I wasn't thinking. I apologize. Yeah.
You don't want to fall asleep eating donuts.
Yeah.
Right.
know how to code this.
Is this the sim person's laptop?
Yeah. No, this is Trish's.
Oh, Trisha, yeah. All right. Nice, cool. We have a scavenger hunt,
What?
active crash cart scavenger hunt. I don't remember what's all these things, different carts. Sometimes I've never actually gone through drawer by drawer.
Yeah.
Oh, let me take it.
Yeah.